the introduction. It's a great pleasure and honor to be here with you this wonderful evening and to be talking about a very important subject. So I only have 15 minutes. I will go through the slides in a bit of a hurry. What makes a good presentation is being short but concise and informative. We should all be proud being OBGYN specialists because observation, baby's interests, generosity, inquiry, and last but not least, nobleness is some of our assets. Now, why are we here today? A very important question. In the letters of the EFRI, we are here to explore current data and to unravel facts, to come to recommendations, which are quite solid recommendations based on evidence. And those types of evidence, we have the Royal College, the NICE guidelines, and the American College, and a lot many others. So we're trying to have a clearer image because only we know the 50% of the truth, and we're moving swiftly to precision medicine, where each and every patient is being treated on her very own specifics. And that's why, if you have a look at how important the topic is, you'll find that 1 out of 4 people die from causes related to blood clots, and it's the #1 preventable death in hospitals. So how common is the problem? Now, the incidence of VTE in women, very unfortunately, not only is increasing with pregnancy and postpartum, of course, but it also increases with advancing age. And this is the unhappy scene of a thrombus. We all know that thrombus is the blood clot in the circulatory system, and it might be as well arterial or venous or in the surrounding tissues. And our arterial thrombus is majorly a platelet-based white thrombus, whereas the venous side, it's a fibrin-based red thrombus. So the Virchow's triad of thrombosis, which we were all taught as students, still applies here in this millennium. Stasis, vessel wall injury, and hypercoagulability, they comprise the important triad of what increases the risk of thrombosis. Here again, very unfortunately, during pregnancy and more importantly, during the postpartum period, pregnant women stand a 4 to 5 times higher risk of developing thrombosis. Almost 10% of all maternal deaths in the States are attributed to this calamity. So 80% of events occur on the venous side, and the importance of which is that it is avoidable and treatable. And that's why we are here tonight, to explore some of the evidence and to come up with some recommendations. So if you have a look there, 50% of VTE events occur in the first 6 weeks postpartum, and that's why it's particularly important to stress on this time frame. And 10% in the first trimester, 10% in the second trimester, and almost 30% in the third trimester. And therefore, so the risk of VTE actually is more important in the third trimester and in the immediate postpartum period. The risk factors are all known to us, increase in most of the coagulatory factors and a decrease in the free protein S. So knowledge gaps, what do we not know now? Now we know a lot, of course. Many questions related to pregnancy-associated VTE remain unanswered. Knowledge awareness of the risk factors is all important. To come to a simpler form of risk stratification is all important because this actually has implications on our current daily practice. So these are the levels of evidence which we are all acquainted with, and the grades of recommendation stretching from A all the way to D, and we should not ignore the role of experts in formulating decisions. So the risk assessment, when should we start assessing ladies for pregnancy, whether it be in the early pregnancy or even in the pre-pregnancy, in the presence of risk factors, or on first booking admission to hospital, or during the intrapartum or immediate postpartum period. And this is, well, it seems a little bit complicated of the Royal College, but here again, we have the high risk, the intermediate risk, and the moderate risk, and the mild risk, and the lower risk. So in the red colors, intermediate risk, and the full color. It's all about having the risk factors. If we have a history of VTE, then it's in the high risk group outside surgery. If we have a number of others like single previous VTE, high risk thrombophilias, medical comorbidities, any surgical procedures, and most importantly, OHSS in the first trimester. Now, moving on to the mild form, where the mild risk incorporates at least 4 of the major risk factors. And you can see here, age, parity, body mass index, gross varicosities, current preeclampsia, and many others. Of course, if you get to use these, it gets simpler as you use them. If you have fewer than 2, then you are at a low risk. Then you need no thromboprophylaxis, just mobilization and avoidance of dehydration, which is part of the ERAS or the enhanced recovery after surgery, is early hydration and early ambulation. What about the postnatal period? Here again, the risk factors are almost the same, and you might as well be using in the high risk and the intermediate risk, the high risk for 6 weeks postpartum, the intermediate risk for at least 10 days, and conditionally thereafter, and the low risk, just be content with mobilization and avoidance of rehab. So the risk factors here, one by one, you should just have a look at previous VTE at the top of the table, and down there at OHSS, the first trimester, both comprise 4. So the strongest and the highest risk. Previous surgery, medical comorbidities, thrombophilias are 3. And then we have cesarean section in labor, which is particularly important in our practice, is 2. Any surgical procedures in pregnancy, it's a transient risk factor. It's not a permanent risk factor. And the remainder of the factor warrants just 1, a score of 1. So to sum up, we have 4 factors antenatally considered thromboprophylaxis from the first trimester. If you're having 3, then from 28 weeks. If you have more than 2 or 2 postnatally for at least 10 days. So this is to sum up the 4 or more risk factors throughout pregnancy and 6 weeks postpartum. Risk factors, if you have 3, then it's from 28 weeks till 6 weeks postpartum. If you have, it's just postpartum for 10 days with nothing given prophylactically antenatal. So what do we use? We use heparins. We all know that unfractionated heparins, and they could be used, of course, versus low molecular weight heparin. They have the advantage of being cheaper, having a shorter half-life, and they can be reversed rapidly. Therefore, they can be a usable alternative to fractionated low molecular weight heparin, especially in the peripartum period or in patients with severe renal insufficiency. So we talk about prophylactic dose, intermediate dose, and therapeutic dose. Low dose molecular weight heparin, it depends on the weight, as you can see. Enoxaparin, for instance, 20 milligrams a day if you are less than 50, 40 milligrams, 50 to 90, 60, 80, and so on. In doses higher, 60 or higher, you are advised to split the dose into halves. So the doses here, if you're using unfractionated heparin, 5,000, 12 hourly, or more frequently as the case indicates. This is a little bit complicated. The Royal College still is applicable here. Here is a list of the major contraindications, most of which are related to bleeding, thrombocytopenia, stroke, severe renal or liver disease, or uncontrolled hypertension. What is the heparin antidote? Of course, it is protamine sulfate and not vitamin K. And warfarin, it can be, as you know, it crosses the placenta. It's potentially teratogenic early in pregnancy, and therefore it's considered in the middle part of pregnancy with those using mechanical valves. However, it's safe in breastfeeding. Anti-embolism stockings, well, one of the non-medical or non-medical treatment strategies. And here again, thromboprophylaxis should be interrupted in any case of bleeding, or if cesarean section is indicated at least 12 hours after a prophylactic dose and 24 hours after a therapeutic dose. When to start? We start vaginal delivery after 6 to 12 hours if no postpartum hemorrhage or no epidural analgesia is used, and 12 to 24 hours after cesarean section. you might as well resort to an earlier resort to or resumption of heparin therapy in selective cases. So in the high-risk women, postpartum for 6 weeks, intermediate for 10 days, where additional factors you might as well extend for 6 weeks selectively. And well, I will only touch on the ECHO guidelines because they are a little bit complicated. So the summary of recommendations will be a level A. Perhaps little, if any of us would disagree that when signs and symptoms suggest a new onset DVT, the recommended initial diagnostic test is compression ultrasonography. And therefore, in general, the preferred anticoagulants are the heparin compounds. A reasonable approach is to minimize postpartum bleeding complication is resumption 4 to 6 hours, no sooner than 4 to 6 hours after vaginal delivery or 6 to 12 hours after a cesarean section. Level B recommendation, because all of those do not cross the breast milk, they can be used during breastfeeding, of course. So the women with history of thrombosis who have not had a complete evaluation of possible underlying etiologies should be tested for APS or antiphospholipid syndrome and inherited thrombophilias, where adjusted dose anticoagulation is recommended in those women with acute thromboembolism in the current pregnancy or those with a high risk. When reinstitution of anticoagulation, postpartum pneumatic compression devices should be left in place until the patient is ambulatory or until anticoagulation is restarted. And women receiving anticoagulation may be converted from low molecular weight heparin to shorter half-life, cheaper cheaper unfractionated heparin in anticipation of delivery, depending on the institutional protocols. And lastly, placement of pneumatic compression devices before cesarean section is recommended. I think this is particularly important for all women, and early ambulation, part of the ERAS, is advised after C-section. What about the NOAC, or the new era of rivaroxaban, apixaban, the direct thrombin inhibitors? They are not, the current recommendation actually advise against using them because they have not been adequately fully tested. So what is this? This is not a power failure. This is not a technical fault. It only tells you that in darkness, you might as well very easily miss your steps. So be careful. So in a nutshell, all women should undergo risk assessment for venous thromboembolism in early pregnancy or pre-pregnancy. The assessment should be according to the case. Both low molecular and unfractionated heparins should be used or could be used for thromboprophylaxis. Low molecular heparins are easy to administer once a day, does not require any monitoring, a little bit more expensive. Any woman with 4 or more current risk factors should be offered prophylactic low molecular weight heparins throughout the antenatal and 6 weeks postpartum. Any woman with 3 risk factors should be offered prophylactic from 28 weeks and 6 weeks postpartum. Any woman with 2 risk factors should be offered prophylactic low molecular weight heparins for at least 10 days postpartum. Short-term thromboprophylaxis should be considered for pregnant women admitted to hyperemesis or ovarian hyperstimulation syndrome, which actually are transient indications. Risk of VTE should be discussed with all women at risk. Necessary precautions, thromboprophylaxis could be started after 6 to 12 weeks, 12 hours, after vaginal delivery, and 12 to 24 hours after cesarean. So here we come to some interesting slides. We as EFRI founders and members, EFRI, of course, it's known to support women's rights because we believe that every female has the right to enjoy a healthy reproductive life. Not only this, the take-home messages for VTE is that it should be validated and not be just personalized, very personalized, validated treatment, which is based on evidence. So the VTE, and not only this, but also that early risk assessment is all important. Fractionated heparin are the best known anticoagulants so far. And resume postnatally is all important because most of the tragic events occur in the postnatal period. And last but not least, it's all about evaluation and surveillance. Thank you very much for your attention.